Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are for mainly for educative purpose. Majority of them will be very useful to fourth year students for your oral exam, as well as some of the topics will be very useful in your theory. Today we are going to deal with one of the very useful topic in your theory, asked as a short note, and very commonly asked in your oral exam, that is cyanosis. And it will be extremely useful in your everyday practice because you will come across this patient. You will have to identify first it is cyanosis or not, and then try to differentiate whether which type of cyanosis it is, and then try to find out the cause of cyanosis. So today we'll be dealing with cyanosis. Cyanosis is one of the symptom as well as sign which you come across on examination. We'll be discussing under all these common heading as usual: definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, and treatment and complication. Actually, complication is mainly because of the basic etiology rather than cyanosis itself. So what is cyanosis? Cyanosis is a bluish discoloration of skin and mucous membrane which is due to presence of reduced hemoglobin, or we call deoxyhemoglobin, more than 5 gram percentage circulating in blood. So this is very important. Reduced hemoglobin, or what we call as a deoxyhemoglobin, which has to be minimum more than 5 gram percentage, and that should be in a circulating blood, that is on arterial blood rather than venous blood. As such, in venous blood it will be more than 5 gram, but that will not provide you cyanosis. Cyanosis can be physiological and may be normal for about 20 minutes. But if it remains for more than that, it is always abnormal. And we basically divide into two groups: central cyanosis, which is because of desaturation of arterial blood, while peripheral cyanosis, there is a normal arterial oxygenation, but because of decreased blood flow, more oxygen is utilized, and at the periphery you get cyanosis, and that is described as peripheral cyanosis. So bluish discoloration of skin and mucous membrane due to reduced hemoglobin or deoxyhemoglobin in capillary blood more than 5 gram percentage, or more than 5 gram per deciliter, or we should not forget this: increased concentration of abnormal hemoglobin derivatives like methemoglobin, sulfhemoglobin in, again, capillary network, that is superficial blood vessel, you will end up with cyanosis. This particular, because of abnormal hemoglobin, is also called as endogenous hemoglobin, and it is also described as pigmentary cyanosis because it is because of abnormal pigments, that is hemoglobin pigments, and that is giving rise to cyanosis. So when you describe a peripheral cyanosis is very frequently because of peripheral vasoconstriction, and this peripheral vasoconstriction is to the exposed part. That's why it is commonly seen in hands and feet. And patient with a central cyanosis will have a peripheral cyanosis because of desaturation, because there will be also desaturating blood circulating in a periphery. But if you get only in periphery and there is no deoxyhemoglobin circulating in the blood, then we use the word isolated peripheral cyanosis, where you will have a localized arterial lesion, and that will give rise to what we call as a peripheral cyanosis. So peripheral cyanosis is because of a peripheral vasoconstriction in a normal person when he is exposed to extreme cold, or because of Reynolds phenomena, which may be primary or secondary, or maybe because of peripheral arterial occlusion. So these three will be the most common cause for peripheral cyanosis. We'll be repeating again that. And that is the reason why person develops peripheral cyanosis. I'm skipping this slide because for explaining this it will take a lot of time, so I'm skipping this. That in a case of severe anemia, it is extremely difficult to get cyanosis, while in case of a polycythemia, even person has got no hypoxia, but still he will develop cyanosis because excess of hemoglobin cannot be saturated, and hence they will develop cyanosis. We'll be explaining in other slides. So there is something called as anemic hypoxia. Here, because hemoglobin concentration is low, in spite of even all hemoglobin, say hemoglobin is 7 gram, all 7 gram is completely oxygenated, still person is having hypoxia. So that is called anemic hypoxia. But here, in spite of hypoxia, person does not have cyanosis because there is no excess of hemoglobin, which is deoxyhemoglobin, more than 5 gram. In a histotoxic, entire hemoglobin is completely oxygenated, but that oxygen cannot be utilized by peripheral tissue. We call it a histotoxic hypoxia, and hence this will also not produce cyanosis because there is no deoxyhemoglobin circulating in the blood. While in case of carbon monoxide poisoning, carboxyhemoglobin is cherry red in color, and being a cherry red in color, you do not have appearance of a blue color. That's why in carbon monoxide poisoning also, in spite of severe hypoxia, you do not have a blue color to the peripheral tissue, that is skin and mucous membrane, because carboxyhemoglobin is cherry red in color. So if a person is having severe anemia, cyanosis cannot develop to detect cyanosis with severe anemia, because here a very small percentage of hemoglobin is a deoxyhemoglobin. While a person will develop cyanosis without hypoxia, means in this group of people, in a arterial blood, hemoglobin is fully oxygenated, like polycythemia, where you will have excess of hemoglobin because the hemoglobin is say 24 gram, out of which say 5 gram, 6 gram, 7 gram is deoxy, 17 gram is completely oxygenated, hence there is no hypoxia. But that excess of 7 gram, which is deoxy, will produce cyanosis, and it will be more of peripheral cyanosis rather than central cyanosis. In Reynolds phenomena, because of arterial spasm, there will be cyanosis. This will be again without hypoxia. As well as in peripheral arterial disease, there will be no hypoxia, but there will be peripheral cyanosis. So as such, we have mentioned in a peripheral cyanosis on cold exposure, Reynolds phenomena, and peripheral arterial occlusion, there will be peripheral cyanosis without hypoxia. So by and large, in a peripheral cyanosis, it will be with, in case of polycythemia, Reynolds phenomena, peripheral arterial disease, and also on exposure to extreme cold. In those conditions, it will be cyanosis without hypoxia. By and large, central cyanosis will run with hypoxia. Now, if we use some terminology, we divide into two big groups. One we call as a true cyanosis, and second word we commonly utilize is pseudo cyanosis. True cyanosis means there is definitely deoxyhemoglobin circulating in the blood, that we call as a true cyanosis, while in a pseudo cyanosis There will be bluish discoloration of skin and mucous membrane, but it is not because of what we call as deoxyhemoglobin more than 5 grams circulating in the blood. Now this true cyanosis will be further divided into central, peripheral, mixed, differential cyanosis, and again in differential cyanosis and reverse differential cyanosis. There is another term also utilized sometime, that is called intermittent cyanosis. There is one another term which is utilized, we call as a pigmentary cyanosis or endogenous cyanosis, which is because of methemoglobinemia or sulfhemoglobinemia. There are some other odd terms also utilized like acrocyanosis. Also labeled same acrocyanosis is also called circumural, that is around the oral cavity, that is lips and tongue, that is called acrocyanosis. And there is one another term called as Ortho Cyanosis. We'll be just giving you explanation there. We already explained central as well as peripheral, but we'll be going in detail. Now, there are some terminology which are also called central. We have told you central, peripheral, mixed, differential, reverse differential, intermittent, circumural, and there is also called as cyclical cyanosis or intermittent cyanosis. And bilateral choanal atresia is the cause for cyclical cyanosis. And these are some of the terms which you can come across related to cyanosis. We'll be explaining those particular terms. There is one more term called as acrocyanosis, and that is same term for circumural cyanosis. There is one term called as orthocyanosis, which is with a posture, and there is a term which is utilized as androgenous cyanosis or pigmentary cyanosis, which is because of sulfhemoglobin and methemoglobin. That is we call pigmentary cyanosis. And there is one more term called as a pseudocyanosis. In peripheral cyanosis, there is normal arterial blood saturation, means there is no deoxyhemoglobin circulating in the arterial side, or we call systemic circulation. But because of diminished blood flow in the periphery, or what we call the distal part of the extremities, or in the circumural area or periorbital area, you will develop cyanosis because of excessive utilization of oxygen. And this is probably produced because of a vasomotor instability. There is a vasoconstriction on exposure to cold, or because of venous obstruction, or because of severe elevated venous pressure, or maybe in a case of a polycythemia where there is an increased hemoglobin, or maybe because of a low cardiac output. This will be all the different etiology for peripheral cyanosis. So I am repeating again, on exposure to extreme cold, venous obstruction, arterial obstruction, elevated venous pressure, polycythemia vera, and low cardiac output. So this will be all the conditions which will produce peripheral cyanosis. While in a central cyanosis, there is a low arterial blood saturation, and this will be because of atmospheric condition, respiratory condition, that is ventilation problems, and because of cardiovascular system, that is we call as a circulation. So these three conditions will be most commonly responsible for central cyanosis. As well as pigmentary cyanosis will produce central cyanosis. So don't forget pigmentary cyanosis. This is classical peripheral cyanosis. This is oral cavity, lips, tongues, extremities are blue. So this is classical example of central cyanosis. So classical peripheral cyanosis where oxygen concentration on an arterial side is normal, while in a central cyanosis always the oxygen concentration is markedly reduced, or indirectly we say central cyanosis is almost always associated with hypoxia. We have given the exception. And because there is a blood which is deoxyhemoglobin circulating in a systemic circulation, so you will have a lips, nail beds, ear lobules, malar prominence, palm, sole, tongue, mucous membrane of gums, soft palate, cheeks, etc. will be blue in color. So when you get in this multiple area, bluish discoloration, you can see here the nasal skin, mucous membrane, lips, peripheral, all are blue. This is classical central cyanosis. Now to differentiate between cardiac causes and respiratory causes of cyanosis. So classical example in a cardiac cyanosis, mainly left ventricular failure, or we call it a congestive heart failure, or we can use the word acute pulmonary edema. While in respiratory it is because of a lung parenchyma. So here the peripheries are cold due to vasoconstriction, because there is a diminished blood flow in the extremities and there is a peripheral vasoconstriction. While here the peripheries are warm, carbon dioxide accumulation will produce peripheral vasodilatation. So extremities are usually warm. Here there will be low volume pulse. Here there will be bounding pulse. The person will have a minimal response to oxygen therapy. That is, if you give a hyperbaric oxygen, that is 100% oxygen. In case of a cardiac cyanosis, usually there will be poor response or no response. So cyanosis may disappear in a pulmonary cases except right to left shunt. Why? In a case of a cardiac, usually there will be no response. Auscultation wise, you will get a basal crackles, or we call basal crepitations, while in respiratory system you will have a bounding pulse, and when you give an oxygen, because of diminished ventilation there is a poor oxygenation. So when you give oxygen, oxygenation is good and it will give a very good response to oxygen therapy, and person will have diminished cyanosis. And on auscultation you will have a prolonged expiration with lot of bronchi, and if there are crackles, it is usually extensive bilateral. And that is the way we try to differentiate between respiratory cyanosis and cardiac cyanosis. Very frequently in a cardiac cyanosis, you will have a central cyanosis plus peripheral cyanosis, we call it a mixed cyanosis, while in respiratory it will be always central cyanosis. So just remember that. So difference between central and peripheral. Here central causes, cardiac and respiratory are most common, while in case of peripheral it is arterial occlusion or venous occlusion, increase in venous pressure, Reynolds disease, polycythemia, exposure to extreme cold, and also a part of severe congestive heart failure. That are the causes in peripheral cyanosis, while in cardiac, atmospheric condition, respiratory condition, cardiovascular condition, and also in case of a pigmentary, that is sulfhemoglobin, methemoglobin. The parts which is affected in a central cyanosis are usually generalized, means lips, tongue, soft palate, pharyngeal wall, oral mucosa, malar eminence, conjunctiva, nail bed, pulp of the finger, toes, all those ear lobules, while in case of localized it is mainly the toes and fingers. By and large in central cyanosis the affected part is warm, but in case of a severe congestive heart failure the periphery may be cold because of peripheral vasoconstriction, while in case of a peripheral cyanosis, because of other than congestive heart failure, the extremities will be cold all the time. But in a congestive heart failure there is a mixed cyanosis, so you will have an element of central cyanosis plus you will have extremities which will be cold. When you apply a little warmness, so you dip your finger and toes in a warm solution or you rub against each other to palm. Now there is a vasodilatation. Peripheral cyanosis will become less or disappears, while there will be no effect as far as central cyanosis is concerned, because there will be no effect, so it does not disappear. Very, very important clue. The blood which is pumped into systemic circulation contains more than 5 gram of deoxyhemoglobin or reduced hemoglobin, while in case of peripheral cyanosis, the blood which is present in a systemic circulation is fully oxygenated. There is a stagnation of a blood flow in a peripheral circulation, hence it will produce peripheral cyanosis. We have already mentioned in a central, generalized, peripheral, localized. Tongue is involved. Tongue, soft palate, lips, oral mucosa, pharyngeal wall, etc. are involved, while here those are not involved. Usually periphery are usually warm except in a severe congestive heart failure, while in a peripheral cyanosis they are usually cold. Clubbing will be very frequently in a chronic central cyanosis, while usually in a peripheral cyanosis clubbing is never present. When you give an oxygen, pulmonary conditions will show you improvement, while cardiovascular condition may not show you as good improvement as pulmonary. While in peripheral cyanosis there will be no improvement at all. So cyanosis will not respond to oxygen therapy if it is cardiovascular and peripheral. When you apply a warmness by rubbing or by putting the hand in the warm water, central cyanosis does not improve, while peripheral cyanosis will have a little improvement. In a central cyanosis, there is a deoxyhemoglobin more than 5 gram in a central blood, or we call it a systemic circulation, while here it is normal and there is a diminished blood flow, hence there is an excessive utilization of oxygen, and that will result into, as in a central cyanosis, there is a diminished blood flow. In a central cyanosis, particularly in a case of a respiratory system, except congestive heart failure, there is a normal blood flow. So capillary refilling time is less than 2 seconds, while in case of peripheral cyanosis, as the blood flow is markedly diminished, the capillary refilling time is more than 2 seconds. Same thing happened, describe area, tongue, handshake, clubbing, oxygen application, warming, mechanism, and capillary refilling time. To differentiate in a mixed and differential cyanosis, in a mixed variety, both central as well as peripheral are same, but here the extremity will be cold, so you will have a central cyanosis with peripheral cyanosis. Massage may produce a little change in a peripheral tissue, that is in extremities. In differential cyanosis, usually you come across in case of Eisenmenger with reversal, that is Eisenmenger is reversal of the shunt with PDA, and in that particular the lower limb, that is two lower limbs, are more cyanosed, the upper limb are spared, because there is a deoxyhemoglobin circulating in the lower limb through a patent ductus arteriosus, and that produces what we call as a differential cyanosis. So in a case of a mixed cyanosis, you have got a peripheral cyanosis which is cold clammy. This will be cold clammy, plus you will have a lips, tongue, sinus. So mixed cyanosis is seen in a severe congestive heart failure. So also in a central cyanosis, due to left ventricular failure and because of a peripheral vasoconstriction, you will have a peripheral cyanosis. So that is a characteristic of a mixed cyanosis in case of a severe congestive heart failure. So in a severe congestive heart failure, you have got a central plus peripheral. So because of cardiogenic shock, you have got a peripheral cyanosis, and because there is a congestive heart failure, there is a deoxyhemoglobin circulating in the blood, and that will produce central cyanosis. And for congestive heart failure, there will be pulmonary edema, which is producing central cyanosis. Androgenous cyanosis, or we call as a pigmentary cyanosis, which is because of abnormal hemoglobin, we call androgenous pigments, and that produces cyanosis, we call as androgenous cyanosis. That is methemoglobinemia, sulfhemoglobinemia. Methemoglobinemia is because of alteration in a hemoglobin status, that is ferrous part, that is iron which is present in the ferrous form in the heme is converted or oxidized to ferric form, and this ferric form of heme has got a poor affinity to oxygen. It usually cannot combine nicely with oxygen, hence the oxygen carrying by a methemoglobin is reduced, and that gives rise to cyanosis. And this methemoglobin may be very frequently because of genetic predisposition, because of genetic abnormality, and precipitating factors like nitrates, which is an oxidizing agents. So there are some compounds which are oxidizing agents like nitroglycerin, nitrates, etc., and that can predispose to methemoglobinemia. While in case of a sulfhemoglobin, again same mechanism, that ferrous is converted into ferric form, but here one of the compound which is responsible is a sulfonamide, and this sulfonamide converts compound into sulfhemoglobin, and that's why we call that as sulfhemoglobinemia. In a sulfhemoglobinemia, the blood is greenish in color. So sulfhemoglobin is little greenish in color, while in case of a methemoglobinemia, it is little brownish in color. We'll show you that. So in a methemoglobinemia, there is an hereditary cause, plus it is exposed to the toxic substance. So more than 15% of the people, you can have 15% of the hemoglobin may be converted, and you will develop cyanosis, and it becomes lethal unless it is treated. And this methemoglobin is chocolatey brown in color, so the color will change into chocolatey brown in color. So that chocolate brown color is because of the poor oxygenation of methemoglobin, because methemoglobin has got a poor affinity to oxygen. While in a sulfhemoglobin, even if 0.5 gram is converted into sulfhemoglobin, it will give rise to hypoxia and cyanosis. While methemoglobinemia, it has to be more than 1.5 gram. In sulfhemoglobin, it will be greenish color of hemoglobin, and here it will be chocolate brown color. And this is the peculiarity between the two. Sulfhemoglobin is very common because of sulfonamides and nitrates, while methemoglobin, genetic factor plus you will have a nitrates, nitroglycerin, aniline dye, etc. And there is a defect in a hemoglobin, we call hemoglobin M disease. That is, hemoglobin M is present, and that will be easily converted into methemoglobin, and that is mainly because of aniline dye and oxidizing agents like nitrates and nitrites. So do remember this. While in case of what we call as a sulfhemoglobinemia, sulfonamide and also nitrates or nitrites may be responsible. There is another hemoglobin which is androgenous but does not give rise to cherry brown color or chocolatey brown color or greenish color, but it is what we call as a pink color, carboxyhemoglobin, because of carbon monoxide poisoning. Hence, in spite of hypoxia, severe hypoxia, and deoxygenated hemoglobin circulating in the blood, still you do not see cyanosis because it is cherry red color. And that's why in a carbon monoxide poisoning, you do not develop cyanosis. So methemoglobinemia can be congenital or acquired. Usually you get a chocolate brown color hemoglobin. ABG will show you normal oxygen concentration. There is no improvement with oxygen therapy because methemoglobin has got a very poor affinity to oxygen. Severe symptoms will depend upon the quantity and rapidity with which the methemoglobinemia develops, and usually it is fatal. And when you give methylene blue, it will be reversible. So the treatment for methemoglobinemia is methylene blue. So that, do remember that. In a sulfhemoglobinemia, it will be greenish in color. That's why this particular picture has been put here. So the fingertips, palm, etc. will appear little greenish color. It is not because of the color. It is because of the hemoglobin color. And that is sulfhemoglobinemia. Do remember that. In differential cyanosis, because of patent ductus arteriosus, normally the blood will always flow from oxygenated side to pulmonary circulation, and that will give rise to pulmonary hypertension. And when you get reversal of the shunt, now blood from pulmonary artery will flow into aorta, and that blood is a deoxy blood, and that blood will flow into descending aorta rather than branches, because if the duct is after the left subclavian, you will have cyanosis in two lower limbs. So we will get cyanosis in these two, while upper limb will be getting oxygenated blood which is coming from LA to LV and into aorta. So upper limb to upper limb and head and neck will not be cyanosis, and this is described as a differential cyanosis. So it is always after reversal of the shunt, and whenever you get a reversal of the shunt with PDA, we call that any reversal of the shunt which was left to right shunt, and now if it has reversed and now it has become right to left shunt, we call that as Eisenmenger syndrome. And there is one another condition which is labeled as reverse differential cyanosis, where lower limb are not cyanosed, the upper limb are cyanosed, and it is seen with transposition of great vessels and patent ductus arteriosus with reversal of the shunt. So you have got a reversal of the shunt with transposition of great vessels, and in that condition you will have reverse differential cyanosis. Means you will have cyanosis in upper limb and head and neck, while you will have no cyanosis in lower limb, and this will be very, very peculiar because of transposition of great vessels. And this, along with patent ductus arteriosus, and you should get reversal of the shunt, very, very odd combination, but theoretical possible, and once in a while in a congenital cyanotic heart disease you can come across. So in a differential cyanosis, hands are blue, hands are red, or we call less blue, feet are more blue, and that will happen in a patent ductus arteriosus with reversal of the shunt, and that we call as a Eisenmenger. And reverse differential cyanosis, we have told you that hands are blue, feet are red, and this will be seen. One condition I have already given you the description, that in a case of transposition of great vessels with patent ductus arteriosus with Eisenmenger, but once in a while in case of coarctation of aorta with transposition of great vessels also, you can have a reverse differential cyanosis. So this will be the two permutation combination where you can have. There is one more variety of cyanosis we call as an intermittent cyanosis, which can happen very frequently in an abstain anomaly. Forget about that. If someone asks you in oral, then only utter that word, intermittent cyanosis in abstain anomaly. In abstain anomaly. So do remember this. There is one word called as acrocyanosis. This acrocyanosis means bluish color of hand and feet and around the oral cavity. That's why it is called circumoral, means around the oral cavity, that is lips and tongue. Along with that you might have hands and feet, that is toes and finger. This mucous membrane, that is good number of time, the central part, that is tongue, buccal mucosa, pharynx remains pink, and this is very frequently because of vasomotor changes, which is taking place, and whenever the person is little exposed to cold, the person will develop a circumural cyanosis, and that is described as Acrocyanosis, and it is very frequently seen in a newborn children. And usually it is not pathological unless cardiac output is extremely low, and that's why in a children you should try to differentiate acrocyanosis from a true peripheral cyanosis. Polycythemia, I have already explained that in polycythemia the hemoglobin is very much elevated. So hemoglobin may be 24 gram or 25 gram, and lung cannot oxygenate at all. So good number of hemoglobin, that is more than 5 gram, will be not oxygenated, so that will be deoxyhemoglobin circulating in a systemic blood, and that will give rise to central cyanosis as well as peripheral cyanosis. And that is the cause of cyanosis in polycythemia, where person is not hypoxic but still he has got central cyanosis. Reynolds phenomena, we have already explained that on exposure to extreme cold, because of what we call as vasomotor changes, the artery, peripheral artery undergoes spasm, and in Reynolds phenomena we will have three phenomena: pallor, cyanosis, followed by rubor, reddish discoloration, three phases, and that gives you a classical diagnosis of Reynolds phenomena. We'll be discussing separately when we come to peripheral arterial disease and Reynolds phenomena. So mixed cyanosis is characteristic in a case of a cardiogenic shock, or we call it a severe congestive heart failure. Well, central cyanosis is because of acute pulmonary edema, and peripheral cyanosis because of shock stage where there is a diminished blood flow in the periphery. Hence, this is a mixed cyanosis. In a polycythemia also, there is a central cyanosis and there is a diminished blood flow. Sorry, here Y is missing. So in a peripheral cyanosis, there is a diminished blood flow because of increased viscosity. So you will have two elements, that is central cyanosis plus peripheral cyanosis. So you can have two mechanisms in a severe congestive heart failure and polycythemia rubra vera. So do remember, even sometimes in a secondary polycythemia also, if hemoglobin is markedly elevated, you can have a hyperviscosity syndrome. So you will have a mixture of both central as well as peripheral. So do remember that. So we'll be getting that. There is one another word which is being utilized is orthocyanosis. Ortho means erect. So whenever a person acquires a erect posture, person can develop cyanosis. So it is present in an upright posture due to hypoxia occurring in an erect posture. Particularly this is classical in case of a pulmonary arteriovenous malformation. Now to explain you that, this is also called as a person when he is in an erect posture, because during an erect posture the AV malformation are open, there is a shunting which is taking place at that AV malformation, and that gives rise to cyanosis, and this is called deoxia. Ortho, so ortho position is giving rise to deoxia, that's why it is called orthodeoxia. And whenever a person lies down, during lying down, the abdominal viscera is compressing the diaphragm, and because the lung is also little bit compressed, the AV malformation are compressed, the shunting will stop, and because now shunt stops, now there is no cyanosis. So a person with orthocyanosis invariably will tell you that he is feeling breathless in erect posture and he feels better in lying down posture, or it is also described as opposite of, classically what we use word orthopnea. So orthocyanosis or deoxia, orthodeoxia, is a classical phenomena just opposite of orthopnea. I've already explained circumural cyanosis, that in a healthy child, because there is a little sluggish blood flow and there is a peripheral vasoconstriction, because of exposure to little cold, a child will develop a circumural cyanosis for a short period and there is no diminished cardiac output, and this is described as a circumural cyanosis, which is good number of time physiological, and hence this disappears after a short period. So that particular cyanosis, circumural cyanosis, is also described as a acrocyanosis. We have already mentioned. So just keep it in mind. It is a bluish discoloration of fingers and lips which takes place, and there is no symptom signs of circulatory shock, and that we call as a acrocyanosis or circumural cyanosis. We have told you true cyanosis can be central, peripheral, mixed, also sulfhemoglobinemia, methemoglobinemia, etc. All those are true cyanosis. Why? Because of other abnormal pigments, there is no cyanosis, there is no hypoxia. Mucous membrane, mouth, all mucous membrane of oral cavity, that is tongue, buccal mucosa, pharynx, soft palates are pink in color. Normal ABG, normal pulse oximeter reading, but you feel there is a cyanosis, and classically you see over the ear pinna. This is very commonly seen with the amiodarone, and also sometimes you see with silver poisoning, that is called argyria, or may be seen with gold therapy, or may be seen with a minocycline, or maybe occasionally seen with chloroquine. Particularly drugs like amiodarone will produce a pseudocyanosis involving the ear pinna and the skin around that. And there is one disorder which is a genetic disorder called as osteogenesis imperfecta, where the sclera will appear blue. It is because of defect in the sclera part of it, and that is producing a bluish discoloration, and it is not because of hypoxia. I'll show you in another photographs. This is a photograph shown in almost all textbook also. This is called Papa Smurf, who drank and applied a colloidal silver for a skin condition. So this is a typical person who is having a pseudocyanosis. So that is a typical. If we go through our etiology part, we can divide into respiratory condition, cardiovascular, blood, high altitude, and peripheral arteries disorders. Now peripheral artery will produce purely peripheral, while respiratory, blood and high altitude will have only pure central, while cardiovascular can have a central as well as mixed variety. So mixed variety will be produced mainly by two conditions. One, severe congestive heart failure, and second, in case of a polycythemia rubra vera. While respiratory, blood pathophysiology, high altitude will be mainly central, and in blood one exception, that is polycythemia rubra vera, can have a central as well as mixed variety. Indirectly, central can be because of cardiovascular, respiratory, blood, atmospheric conditions, while peripheral will be because of severe congestive heart failure, which can have peripheral element, as well as because of peripheral arterial disease, that is we call arterial disease. Mixed variety will be because of acute left ventricular failure, or we call as acute pulmonary edema, or we call as a severe congestive heart failure. Plus, I've forgotten to mention polycythemia rubra vera. And differential cyanosis will be there in case of a patent ductus arteriosus with Eisenmenger, while there is another variety which we call as a reverse differential cyanosis, where you will have a patent ductus arteriosus with Eisenmenger that is reversal of the shunt, plus person has got what we call as a transposition of great vessel, 3 anomaly. So in that condition, or person has got transposition of great vessels with coarctation of aorta. So in that case also you can have reverse differential cyanosis. We'll explain in a congenital heart disease in detail. So central cyanosis, high altitude, respiratory distress, cardiovascular condition and abnormal hemoglobin. While peripheral cyanosis, extreme exposure to cold, severe congestive heart failure, peripheral arterial disorders like Reynolds Phenomena and arterial blocks, and even venous obstruction. All these conditions will produce peripheral cyanosis. Also, do not forget, peripheral cyanosis can be also a part of acute left ventricular failure or acute congestive heart failure, and as well as in case of a polycythemia rubra vera or polycythemia, where hemoglobin is markedly elevated. So we divide into pulmonary, cardiovascular, hemoglobinopathies, or we call as a pigmentary cyanosis or endogenous cyanosis, endogenous pigments. Pulmonary will produce central cyanosis. There will be central causes, local causes, ventilation perfusion mismatch, alveolar hypoventilation or diffuse impairment, while cardiac will be because of increased pulmonary blood supply, but still person is having cyanosis, and because of decreased pulmonary blood supply, still person develops cyanosis. So we'll be going into pathophysiology separately. Peripheral cyanosis, we have given you a classical example, extreme exposure to cold, peripheral arterial obstruction, L for acute left ventricular failure with shock stage, or we call as a severe congestive heart failure with shock stage, or we call acute pulmonary edema with shock stage. And decreased cardiac output will be because of congestive heart failure. And in case of a acute left ventricular with shock stage, it will be peripheral plus central. So that will give rise to what we call the mixed cyanosis. So do remember that. While in a peripheral central cyanosis, if you want to remember this way, better remember with individual system. Polycythemia, maybe primary, maybe secondary. Polycythemia primary is polycythemia rubra vera, and secondary is because of secondary polycythemia, that is because of COPD, chronic hypoxia, that condition. High altitude, pulmonary conditions, we call pigmentary, that is methemoglobinemia, sulfhemoglobinemia, and even you can describe as a shunts like AV shunts, or a shunt has been done particularly because of left to right shunt or right to left shunt in a case of a cardiovascular disorders, particularly congenital cyanotic heart disease. Those we call as a shunt. Respiratory condition, lot of conditions, upper airway obstruction, ARDS, meconium aspiration, pneumonia, then primary pulmonary hypertension, pulmonary hypoplasia, bronchopulmonary dysplasia, congenital diaphragmatic hernia, asthma, COPD. You can label as many as conditions. Central nervous system, very odd. In case of a severely raised intracranial pressure with herniation, we call asphyxia neonatorum, status epilepticus or continuous seizures, and oversedations, or we call as CNS depression. All these conditions can produce diminished respiration. As far as the cardiovascular system is concerned, we always use cyanotic congenital heart disease, which are mainly right to left shunt, Classical example TOF, we call it tetralogy of Fallot, transposition of great vessels, total anomalous pulmonary venous drainage, truncus arteriosus, tricuspid atresia, and also we call as a ectopia cordis. That is, heart is outside and it is with severe what we call as cardiovascular anomaly. You can have ectopia cordis. There will be many more conditions. We are not going into detail at present. And also in a cardiovascular condition, we call it a total acardia. Very, very rare. Child do not survive. Reversal of the shunt in left to right shunt, we call Eisenmenger. They are cyanosed. And good number of time I've already mentioned two conditions, that in a case of a Eisenmenger syndrome with PDA, that is person will have a differential cyanosis, and if a person has got Eisenmenger, PDA, and if he has got transposition of great vessel, he will have a reverse differential cyanosis. I've already shown this particular slide, so I'm skipping over this particular slide. This I will explain in detail in a chapter of hypoxia. You can go through in that. I'm brushing up very fast. Any atmospheric condition where the oxygen concentration is low, or any pulmonary condition where the ventilation is poor, and because of that the oxygenation becomes poor, and that deoxy blood, if it is circulated by a heart to the periphery, person will develop central cyanosis. So high altitude, respiratory condition and cardiovascular condition will produce central cyanosis. As well as if there is an abnormal hemoglobin, say like sulfhemoglobin, methemoglobin, you will have a central cyanosis. But because of anemia, you will not develop cyanosis. And in a histotoxic condition also, you will not develop cyanosis. Histotoxic hypoxia, that is cyanide poisoning, you will not develop cyanosis. Now, if a person develops peripheral arterial disease, that is a blood supply to the extremities becomes markedly reduced, then in that case you will have peripheral cyanosis. So peripheral cyanosis will develop in a person who has got diminished blood flow in an extremity because of arterial occlusion, or because of hypoviscosity syndrome like in a case of a polycythemia, or you have got a venous obstruction which also reduces the blood flow in the extremities, or because of a peripheral vasoconstriction like in case of a Reynolds Phenomena, or in a peripheral arterial disease. Also in a normal person, when he is exposed to extreme cold, he can develop peripheral cyanosis, or because of diminished cardiac output, coarctation of aorta, there will be diminished blood flow. In all these conditions, you can develop peripheral cyanosis. Clinical features will depend upon the types, like whether it is true cyanosis or pseudocyanosis, or it is a temporary like Acrocyanosis or Circumural Cyanosis, or Ortho which is very common. Whenever the person stands up, he feels breathless and he is cyanos. Classical example of that is pulmonary AV malformations. Also there is one more condition where you can develop dyspnea and person may develop cyanosis in a case of a left atrial myxoma and left atrial thrombus. We can occlude the mitral valve opening in an ortho position. So it can happen, that is cyanosis will develop depending upon the change in the position. And in a case of a left atrial myxoma or what we call as a left atrial thrombus, it can be also what we call as a tripopnea. Person can develop a tripopnea. Okay, we'll discuss that in a dyspnea chapter. While true cyanosis can be central, peripheral, mixed, differential, reverse differential, and occasionally intermittent cyanosis, which is one of the example in a case of what we call as Epstein anomaly. Also, you will develop a true cyanosis and which will be a central variety in case of a methemoglobinemia or sulfhemoglobinemia, and we call this as a androgenous cyanosis or pigmentary cyanosis, and this is because of an abnormal hemoglobin. We already mentioned before that in case of a central cyanosis, all these structures will be cyanosed, that is lips, nail beds, ear, malar eminence, palm, soles, tongue, mucous membrane. While in case of a peripheral, mainly palm and soles will be involved, while lips, mucous membrane will not be commonly, tongue will not be commonly involved. You can have a palm sole along with malar eminence, ear lobules, nail beds may be involved in case of a peripheral cyanosis. This is pallor, and you can see here cyanosis. This is classical example of a Reynolds phenomena. You can see only 1, 2 fingers, 3 fingers. This is not involved. Again, this has to be a peripheral only. You can see here, this is gangrene. This has to be peripheral. Here you can see that the person is developing an entire lower limb getting involved. And in a lower limb, you are getting mainly the sole part of it and the toes. This has to be a peripheral. We have already shown you the difference between peripheral and central. This is a central cyanosis. You can see lips, tongue are cyanosed. You can see lips are cyanosed. These are nails are also cyanosed. Your lips are cyanosed. And even you can see a little change in the color in the nasal skin. These are what we call the central cyanosis. You can see your lips and these are cyanosed. You can see this is similar. If you get only cyanosis in the lips only and in the central part, that is the tongue, buccal mucosa is not cyanosed, is pink. In a children, always suspect acrocyanosis. Here you can see only this portion is cyanosed. So this is peripheral cyanosis. This is peripheral cyanosis. Here you can see gangrene. It is only one part is involved. So this has to be a peripheral. And this has to be arterial, because gangrene will be very frequently in a arterial occlusion rather than venous. This is classical Reynolds phenomena, pallor, cyanosis, and then rubor. That is pallor followed by cyanosis followed by redness. So that will be very, very peculiar. So do remember, you can come across this in a case of a Reynolds phenomena, which can be primary or can be secondary. We are not going to differentiate that. Here, the fits are more involved as compared to the upper limb. This is very common in case of a differential cyanosis. Sometimes left upper limb and 2 lower limbs are involved if the patent duct is before the left subclavian. So that is a classical example of a differential cyanosis. And if it is after the left subclavian, then 2 upper limbs are spared, 2 lower limbs are involved. This is, we call it a pseudocyanosis, which is a classical example in case of amiodarone. In Argyria, entire face, skin, etc. can be involved. We call silver gray skin. And in osteogenesis imperfecta, only sclera will be little bluish in color. In case of a carbon monoxide poisoning, you will have a cherry red color. Whenever you see a person with cyanosis, a good history gives you a lot of answer. Onset and duration is very, very important. Sudden onset is very frequently in case of a cardiovascular system and respiratory system. Try to observe which part of the body is being cyanosed. So you can rule out central cyanosis, peripheral, mixed, differential, reverse differential, and pseudocyanosis. And also you can differentiate acrocyanosis, orthocyanosis, depending upon the history and examination finding. Try to get a good history regarding associated symptoms and look for the signs which will help to differentiate respiratory and cardiovascular conditions, and also peripheral disorders which will help to differentiate peripheral cyanosis. If person has got dyspnea and clubbing, it is more in favor of what we call as a chronic hypoxia, which is more frequently in case of a respiratory system and in case of a cyanotic congenital heart disease. So go through a good history, onset duration, whether it is central or peripheral, look for clubbing, look for oxygen concentration by pulse oximeter, and then you can try to identify the type of hemoglobin by spectroscopy or spectrophotometry examination, or you can go for what we call as a differential findings for finding out the type of hemoglobin, whether there is dyspnea plus clubbing and cyanosis together, or there is a dyspnea without hypoxia, etc. Try to identify that. So this is peripheral cyanosis, this is peripheral cyanosis, this is acrocyanosis. Try to identify all those, and in children always keep it in mind, acrocyanosis. This is a patient of polycythemia, so will give you a central cyanosis. So tongue is blue, lips are also blue. You have got clubbing with cyanosis, so it will be more in favor of what we call as cyanotic congenital heart disease or chronic hypoxia in case of respiratory conditions which will produce cyanosis plus clubbing. And if a person is acquiring a sweating posture, this will be very peculiar in case of a Fallot's tetralogy with reversal of the shunt, Einstein-Menger. Investigation, in this particular, not for reversal. In a case of a tetralogy of Fallot, you will get what we call as a cyanotic spells or TAT spells, and person will get relief after acquiring this squatting posture. This is very peculiar in case of what we call as a tetralogy of Fallot. We'll be explaining you when we come to the cyanotic heart disease, congenital cyanotic heart disease. As far as investigation is concerned, first you have to identify the peripheral arterial concentration either by ABG or by pulse oximeter. So you try to identify that. Then you can go for what we call as a complete history, good physical examination, cardiovascular respiratory system examination, examination of pulses, and then you can go for a X-ray chest. For respiratory condition and cardiovascular condition, you can have a ECG, echo, right heart catheterization or angiography to find out the cardiovascular conditions, and you can use a spectroscope or spectrophotometry for identifying the type of hemoglobin, that is sulfhemoglobin, methemoglobin and carboxyhemoglobin. You can utilize those investigations. Yes, CBC, that is hemoglobin, will be very helpful to identify anemia or polycythemia. That will be very, very important. Sepsis, which will produce, we call as a peripheral shock, will be helpful to identify septic shock, which will differentiate from a cardiovascular shock and septic shock, where WBC count may be altered. You might have a leukopenia or leukocytosis. Methemoglobinemia will be chocolate brown color, while in a sulfhemoglobinemia it will be green color, and carboxyhemoglobin will be cherry red color. ECG, echo, chest X-ray, angiography, etc. Doppler, all those will be useful for cardiovascular condition, etc. You should go for. Pulmonary function test will be useful to identify restrictive or obstructive lung disease, and you can go for a further detailed pulmonary function test. I have already given you this difference in previously, that is oxygen concentration. If you give a hyperbaric oxygen to a person, in case of a cardiovascular system, it will not give you good results. That will tell you that it is a cardiovascular condition, while in case of pulmonary conditions, it will give you a good results, which will suggest that that is respiratory condition. So that is called hyperoxia test. If you give 100% oxygen and if you get improvement, then it is a lung disorders. If you give less than 100 millimeter of mercury pressure oxygen, then if there is a response, it is more in favor of intrapulmonary shunts with normal heart. And if you give less than 10 to 30 millimeter of mercury and slowly increase to 100, Then it suggests intracardiac right to left shunt. These are the way you try to differentiate. And this is one of the method to differentiate these three groups by giving hyperbaric oxygen, or we call hyperoxia test. We have already mentioned all this. Methemoglobin, then hematocrit, etc. We have gone through. Management will depend upon treat the basic cause, and we have already mentioned that if there is only ventilatory problem, that is because of lung, then it can be treated very well with supplementing the oxygen. We call it the oxygen therapy, which can be invasive or non-invasive therapy. It will not be useful in a person with peripheral arterial disease or in a person with what we call as sulfhemoglobin, methemoglobin, carboxyhemoglobin. So in these conditions, it will be helpful. Lung disorders, transposition, large, or we call it a transposition. This is total anomalous of pulmonary venous drainage, then intrapulmonary shunts, and intracardiac, that is right to left shunts. In this condition, oxygen therapy will be beneficial. So give oxygen, particularly while giving oxygen, you should see that the airway is patent, a proper oxygen concentration is maintained, a proper ventilation is maintained, and you correct the metabolic abnormality and you reduce the respiratory distress. But while correcting the oxygen by oxygen therapy, do pay attention to what we call as a washout of carbon dioxide. Person can develop apnea, and if you give a hyperbaric oxygen for a long period, you can get what we call as a oxygen toxicity, and that I will discuss in chapter of hypoxia. You can go through in detail. As far as treatment of cyanosis, it is always symptomatic. In a peripheral cyanosis, warming of the hand can help you out, but in case of a central cyanosis, you will have to treat the underlying basic etiology. So oxygen therapy, as far as cyanosis is concerned, you have to think of it will be mainly useful in a selective group. We have already shown you the slide before. If it is because of the cardiovascular condition, treatment of congestive heart failure will reduce the amount of failure and it will reduce cyanosis also. And in some of the condition, you might require even surgical intervention. Complication will depend upon the basic etiology, the cause of cyanosis, and also it will depend upon the severity of hypoxia. Also, while giving oxygen therapy, complication can develop because of oxygen therapy we call as oxygen toxicity. So I will end my lecture here. Along with cyanosis, you can develop a clubbing, cyanotic spells, depressed IQ because of a hypoxic damage to the brain. Person can have in a cyanotic heart disease, infective endocarditis, which can produce complications. So we always mention complication because of basic etiology. Because of chronic hypoxia, person can develop polycythemia, and secondary to polycythemia, this will be secondary polycythemia, and person can develop lot of complications because of secondary polycythemia, including hyperviscosity syndrome, hyperuricemia, etc. And also a person who has got a congenital cyanotic heart disease, who has developed cyanosis, can also develop a thromboembolic phenomena. So there are a lot of complications because of the basic etiology. That also you should keep it in mind. So I end my lecture here. This is very frequently asked in your theory as a short note. Very rarely can be asked as a full questions, but most frequently asked in your oral. So do remember, this will be very helpful to you in your theory as well as oral exams. Also, it will be very helpful to you in your everyday practice. I feel this lecture will be helpful. If you also feel that is helpful to you, do press button like, subscribe, and you can share with your friends. At the end of this lecture, I thank you all for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. See you in next lecture.